I'm Shyam Varadarajulu from Orlando Health Digestive Health Institute. And on behalf of the faculty of the Institute, I would like to welcome you to the Digestive Diseases Week 2023 update. So this is a program happening in person in Orlando, Florida. And for those of you joining us from around the world online, we are here physically meeting with our faculty colleagues from the Institute, our professional colleagues from Central Florida, and some industry representatives. So this program, we have selected about 35 abstracts, which we consider are clinically very relevant. And they're also based on sound study methodology that will have a good impact on your clinical practice. We have divided those abstracts into different sections. First will be advanced endoscopy, followed by general gastroenterology, IBD, pancreatology, and then finally liver diseases. The abstracts will be presented by the Digestive Health Institute faculty, Dr. Jiang Bang, Mitali Agarwal, and Arvind Murali. For any symposium, we always invite Girish Mishra, who's a very good friend of ours. He, like me, he trained in Charleston, South Carolina with Peter Cotton and Robert Haas. He went on to develop a very successful academic career at Wake Forest, where he's now the chief of gastroenterology. So Girish has been tasked with moderating this session, and he will be spending the next 90 minutes going through these abstracts and reviewing these sessions along with my colleagues. So for everybody around the world, and for those of you gathered here in Orlando, my sincere gratitude for joining us, and we will get this started. Girish.
Good evening, everyone. Before a couple of words, happy Mother's Day to all the moms. I think, right? You know, none of us would be here if it wasn't, you know, for the guidance, encouragement of our mothers. So just before Mother's Day, I think it you know, certainly is worth mentioning. I'm going to come back and review the slides, right? I'm going to moderate after G presents some slides. Just a couple of words. I think the beauty of our specialty is, you know, Dr. Hawes and I were speaking earlier, it's all about the relationships and the mentoring, mentee relationships, right? I was one of Rob's younger pups or boys, if you want to call it. And I think I mentioned last year that very few people thought that I would amount to anything, but and maybe I haven't amounted to anything, but Rob's the one that you know, encouraged me and said, Girish, you know, you need to stick with it with academics. All of you, thank you for coming out today. Today's really special because I'm connected to Rob. Shyam's like a brother to me. All of you are, you know, somewhat related in a way, and I thank all of you for inviting me. But I have two of my former medical students that I maybe had a role in them choosing GI from University of Florida back in 1998, 1999. So here they are almost 24 years later, and we have maintained that bond and connection, just like all of us do. And that's what life is about. And I think why this evening is so special, because it's not just professional, it's about these relationships. Shyam and Rob and, you know, Uday and G and Dr. Agarwal, just a couple words that I, before we dive into the nitty gritty part. What happened to the mic there? Sorry. Rob knows Coach K and has heard of Coach K. I don't know Shyam and others. Coach K is a basketball coach for Duke University, and that's where I happened to go to college. Also the Olympic coach for the basketball team. And what made him so successful as a leader, it's not just about basketball games and wins and losses. It's how do you motivate people? How do you build a team? And there are a lot of leadership books that are out there. But one of the books that he wrote is called Leading with the Heart. And it'd be a great read if you do follow some, you know, basketball. If you don't, it may not be as interesting because everything is, you know, he kind of associates it with basketball. And there are two things that stick out from that book. And I think I just want to leave the entire team, the Orlando Digestive Health team is a powerhouse. And what Coach K said, two things. One is that anything that is worthwhile takes time. Very simple statement. You know, what you're building and what you've already built is special. But don't lose track and don't get discouraged, because anything that's worthwhile takes time. And the other thing is that if you lead from the heart, right? We want to lead from the mind, lead from the gut. But if you lead from the mind, lead from the heart, it will be extra special. And I think you all have poured your heart, souls, gut into what you're doing, and it will be extremely uber successful. So have patience, don't cut corners, which I know you won't, and it'll be a great, it's already becoming great, so.
Much, Dr. Mishra. Hello, good evening, everyone. Welcome to everyone also joining online. I'm going to start off the abstract review with endoscopy update. All right, so our first study is looking at the lack of effect of endoluminal RFA on survival and stent patency in patients with cholangiocarcinoma and pancreatic cancer. This is the results of a randomized trial. So endoluminal RFA has been suggested as a promising treatment modality for palliative treatment of cholangiocarcinoma and pancreatic cancer. In a randomized trial, these authors wanted to compare endoluminal RFA plus stenting with stenting alone as treatment in patients with malignant biliary obstruction, with survival as the primary outcome and stent patency as the secondary outcome. These authors enrolled 161 patients with malignant biliary obstruction. This included 85 patients with cholangiocarcinoma and 76 patients with pancreatic cancer, and they were randomized to either RFA and stenting or stenting alone. The recruitment for the study was terminated early for futility after interim analysis. They found that there was no difference in survival in patients with cholangiocarcinoma or pancreatic cancer in the two groups. Furthermore, there was no benefit in stent patency in both cholangiocarcinoma patients and pancreatic cancer patients. They saw no difference in adverse events between the two groups. So in conclusion, in patients with malignant biliary obstruction, endoluminal radiofrequency ablation, in addition to stenting, was not superior to stenting alone in prolonging survival or stent patency. Our next study is looking at pure cut or endocut for biliary sphincterotomy. This was a multicenter randomized trial. The aim of this study was to evaluate outcomes of pure cut and endocut current modes during biliary sphincterotomy. From 2019 to 2021, consecutive patients with native papilla undergoing biliary sphincterotomy were randomized to either pure cut or endocut. Of this study was the primary outcome was post-ERCP pancreatitis incidence. Secondary outcomes included bleeding, infection, and perforation. 550 patients were enrolled in the study, 272 patients to pure cut, 278 patients to endocut. The overall rate of post-ERCP pancreatitis 4% and was significantly higher in the endocut arm. On multivariate analysis, more than 5 attempts at cannulation was a factor for post-ERCP pancreatitis, and there was a trend towards endocut mode being a significant risk factor for post-ERCP pancreatitis. Intraprocedural bleeding occurred more often with pure cut. Delayed bleeding, however, was more frequent with endocut. There was no difference in adverse events between the two groups. So endocut is associated with higher rates of post-ERCP pancreatitis and delayed bleeding, but pure cut was associated with increased intraprocedural bleeding. Therefore, these authors proposed that pure cut should be the preferred electrocautery mode for biliary sphincterotomy. Our next study looks at endoscopic snare papillectomy for ampullary adenomas, and they wanted to look at predictors of incomplete resection and post-papillectomy pancreatitis. The aim of this study was to determine the risk factors for incomplete resection of ampullary adenomas following endoscopic snare papillectomy, as well as impact of rectal indomethacin and pancreatic duct stenting on post-papillectomy pancreatitis. This was a retrospective multi-center study of patients undergoing index endoscopic snare papillectomy for ampullary adenomas. The authors also performed logistic regression analysis to identify predictors for residual disease and post-procedure pancreatitis. The authors included 136 patients. The median adenoma size was 2 centimeters, and 35% of the ampullary adenomas were laterally spreading. Common bile duct extension was seen in 19% of patients. On-block resection was able to be performed in 57% of patients, and median follow-up in the study was nearly 900 days. Residual neoplasia was seen in 49% of cases. On regression analysis, factors associated with residual adenoma were biliary extension of the adenoma and piecemeal resection. Whipple surgery was ultimately required in 13 patients. Post-papillectomy pancreatitis occurred in 15% of cases. Prophylactic pancreatic duct stenting was successful in 90% of patients, of whom 51% underwent pancreatic stenting alone, and 49% received indomethacin along with pancreatic duct stenting. Decreased rate of post-papillectomy pancreatitis was seen with pancreatic duct stenting, but not with rectal indomethacin alone or in combination with pancreatic duct stenting. In conclusion, residual adenoma was seen in nearly half of patients with ampullary adenomas after endoscopic snare papillectomy. Bile duct extension and piecemeal resection were predictive of residual disease, and endoscopic snare papillectomy was associated with a 15% rate of post-papillectomy pancreatitis, which was lowered by pancreatic duct stenting. Next study looks at ESD or endoscopic submucosal dissection in IBD patients for visible dysplasia. The aim of this study was to assess the short and long-term efficacy of ESD for visible dysplasia in IBD patients. This was a retrospective multi-center study, which included consecutive IBD patients with visible dysplasia who underwent ESD. The primary outcome measure was R0 resection. The study included 89 lesions in 83 patients, which included 20 patients with Crohn's disease. The mean follow-up was 26 months. The median IBD duration in these patients was 21 years. 50% of UC patients were E3 disease, and CD patients or Crohn's patients, 68.4% were L2 disease and 26.3% were L3 disease. On block resection, R0 resection and curative resection were achieved in 91%, 80%, and 77.5% of lesions, respectively. One patient required surgery for complications. 3 patients who failed ESD underwent surgery, and 6 patients underwent surgery for bad prognostic histological features after ESD. Traction strategy was used in 53 cases, providing higher on-block resection rates of larger and severely fibrotic lesions. High volume centers, so those performing more than 100 colorectal ESDs per year, were able to perform larger and faster resections with less recurrences. Recurrence was more frequent in Crohn's patients compared to UC patients. In conclusion, on-block and R0 resection in IBD dysplasia is close to those obtained from ESD for sporadic neoplasms. Perforation was higher, confirming that more complex lesions should be reserved for high-volume centers. Our next study is a randomized trial from our group looking at direct endoscopic versus step-up transluminal interventions in necrotizing pancreatitis. We wanted to compare the outcomes between direct endoscopic necrosectomy and index session versus step-up approach in patients with infected necrotizing pancreatitis. So we performed a multi-center randomized trial comprising 70 patients with confirmed or suspected infected necrotizing pancreatitis. Patients were randomly assigned to endoscopic necrosectomy at index treatment after placement of luminal metal stents, or step-up approach, whereby necrosectomy was performed only if there was no clinical improvement. The primary endpoint was the number of reinterventions required to achieve treatment success, which was defined as symptom relief in conjunction with disease resolution on CT at 6 months. The mean number of reinterventions required for clinical treatment success was significantly lower in patients who received necrosectomy at index session at 0.9 versus 2.5 in the step-up approach group. Also, while overall length of stay was significantly shorter in the direct necrosectomy group at 9 days versus 19 days, there was no significant difference in treatment success, mortality, adverse events, and the mean number of readmissions between the two groups. So in conclusion, direct endoscopic necrosectomy at index procedure compared with step-up approach significantly reduced the number of reinterventions to achieve treatment success and decreased the length of hospital stay. So this is a quick video showing the treatment of one of our destined randomized trial patients. So this patient was actually randomized to the step-up group. As you can see, the patient was very sick, ASA class 4, septic, underwent drainage initially with luminal middle stent. The patient remained sick, ASA class 4, still septic, while cell count of 31,000, so underwent endoscopic necrosectomy. After that, the patient was still sick, while cell count was actually rising, remained ASA class 4, still septic, underwent another session of endoscopic necrosectomy. And then the patient actually went to repeat drainage of a different collection. And then as you can see, we had some bleeding after stent placement, still very sick, ASA class 4, septic. Then we performed another endoscopic necrosectomy. And then by session 6, the patient was becoming more stable. The collection had become more organized. We performed another endoscopic necrosectomy. And finally, session 7, everything is cleaned out. The patient actually did really well and was discharged home. All right, so our next study is looking at the efficacy and safety of permanent transmural double pigtail plastic stents after resolution of pancreatic fluid collections. This was a meta-analysis. To overcome the efficacy and safety of leaving permanent double plastic pigtail stents versus standard stent removal, these authors performed a meta-analysis to compare the efficacy between the two treatment strategies in patients who underwent endoscopic transmural drainage. These authors included studies comparing outcomes of permanent double pigtail plastic stent placement and standard stent removal, and they excluded studies with less than 6-month follow-up, less than 10 patients, abstracts. Outcomes measured after PFC resolution were PFC recurrence, need for interventions, adverse events, after placement of double pigtail stents, and technical success for placement of double pigtail plastic stents. These authors included 16 studies in this meta-analysis comprising 1,285 patients who underwent standard stent removal at the time of PFC resolution had a 4.6 greater odds of developing recurrent pancreatic fluid collection and a 2.8 greater odds of needing a reintervention. The pooled long-term adverse events included spontaneous migration in 6% of the cases, perforation in 1%, and ulcers in 1%. The overall technical success of double pigtail plastic stent placement was 93%, and this was significantly lower for patients who had metal versus plastic stents at the time of index drainage. In conclusion, permanent transmural double pigtail plastic stent placement after PFC resolution is safe and superior to standard stent removal in reducing the risk of PFC recurrence and reinterventions. Our next study is the quality of US-guided liver biopsies and comparing that with traditional liver biopsy methods. The aim of this study was to compare the safety and efficacy of US-guided liver biopsy with percutaneous and transjugular liver biopsy methods. These authors performed a retrospective review of liver biopsies conducted from 2021 to 2022. They extracted data that included the degree of fragmentation of the specimen, number of portal tracts, histological adequacy, the longest length of core tissue, and the rate of adverse events. Adequate portal tracts was defined as greater than 11 portal triads in the obtained specimen. So these are the results. So as you can see, if you look at the EUS group compared to percutaneous and transjugular groups, the adequacy of the biopsy is the lowest for EUS. The degree of fragmentation is the highest for EUS. The specimens with greater than 11 portal tracts is lowest for EUS, and the rate of complications is highest for EUS. However, the mean length of core, the longest length of core was highest with EUS at 1.85 versus 1.8 and 1.34 centimeters. So in conclusion, EUS-guided liver biopsy does not appear to perform as well as percutaneous or transjugular liver biopsies. Our next study looks at surveillance for presumed branch duct IPM of the pancreas, looking at stability, size, and age to identify targets for discontinuation of surveillance. The aim of this study was to identify where the risk of cancer is equivalent to age-matched population, thereby justifying its continuation of surveillance. International multi-center study was performed involving patients with presumed branch duct IPMN without worrisome features or high-risk schemata at diagnosis who underwent surveillance. Clusters of individuals at risk of cancer development were defined according to the cyst size and stability for at least 5 years, and age-matched controls were used for comparison using standardized incidence ratios for pancreatic cancer. Of 3,844 patients with presumed branch duct IPMN, 22% of patients developed a worrisome feature or high-risk stigmata after median surveillance of 53 months, and 4.3% of these patients underwent surgery. From the overall cohort, 42% of the patients remained stable without developing worrisome features or high-risk stigmata for at least 5 years. In patients who are aged 75 years or over, the standardized incident ratio was 2.23, and in patients with who were at least 65 years in age with stable lesions that were less than 50 millimeters in diameter after 5 years, the standardized incidence ratio was 1.7. So in conclusion, surveillance discontinuation could be justified after 5 years of stability in patients older than 75 years with cysts that are less than 3 centimeters, and in patients who are 65 years or older who have a cyst that's less than 15 millimeters. Our next study is a multi-center blinded validation of the diagnostic utility of cyst glucose and amphiregulin to differentiate mucinous from non-mucinous pancreatic cysts. The aim of this study was to examine the usefulness of glucose, amphiregulin, and CEA in differentiating mucinous from non-mucinous cysts. These authors took 292 cyst samples who had surgical histology that were obtained from multiple centers, and the samples were then sent to a central site for blinding. The blinded samples were then used to measure cyst glucose and amphiregulin. Cysts with glucose levels of less than 50 milligram per deciliter were classified as mucinous, and cysts with amphiregulin levels greater than 120 pg per milliliter were classified as mucinous. Primary outcome measure was to determine if glucose or amphiregulin could differentiate mucinous and non-mucinous cysts. Glucose was able to differentiate mucinous with non-mucinous cysts with an area under the receiver operating characteristic curve of 0.88 and sensitivity of 90% and specificity of 78% at a pre-specified threshold. Amphiregulin was able to differentiate mucinous and non-mucinous cysts with area under the receiver operating characteristic curve of 0.6 and sensitivity of 65% and specificity of 47%. CEA was used as a basis for comparison and had an area under the receiver operating characteristic curve of 0.92 and sensitivity of 60% and specificity of 96%. In conclusion, glucose demonstrated a high diagnostic utility to differentiate mucinous from non-mucinous cysts, and glucose had a greater sensitivity while CEA had the greatest specificity. Next, we're looking at EUS-guided gastroenterostomy for management of malignant gastric outlet obstruction. The aim of this study was to look at to assess the EUS-guided gastroenterostomy for the treatment of malignant gastric outlet obstruction. And these authors included consecutive patients undergoing EUS-guided gastroenterostomy in a registry at a tertiary center. And they were followed up monthly. Primary outcome measure was clinical success, and they defined that as the ability to tolerate soft, solid foods. Adverse events and long-term dysfunction were secondary outcome measures. 51 patients underwent EUS-guided gastroenterostomy by the freehand method using an electrocautery-enhanced luminal metal stent of 20 millimeters in diameter. Technical success rate was 98%, and clinical success rate was 98%. Adverse events were recorded in 11.8% of patients. 3 were moderate, 1 was severe, and there were 2 deaths due to exacerbation of a pre-existing cholangitis. The median hospital stay was 6 days. At median follow-up of 73 days, the recurrence of gastric outlet obstruction was noted in 6.3% of the cases, and the median estimated dysfunction-free survival on Kaplan-Meier analysis was 376 days. In conclusion, US-guided gastroenterostomy shows excellent efficacy in relieving malignant gastric outlet obstruction with an acceptable safety profile and long-term patency. Our next study looks at GERD and its sequelae after PERM. The aim of this study was to look at the impact of PERM on GERD. These authors performed a retrospective study looking at patients who underwent PERM between 2012 and 2022. Per protocol, these patients were followed up at 3 and 12 months and then every year thereafter post-PERM, and included upper GI endoscopy, high-resolution manometry, and pH monitoring at 3 months. Then these authors performed an upper endoscopy at 2-3 years and then at 6 years post-PERM. The main outcome measure was looking at reflux esophagitis, complications of reflux parameters as measured by 24-hour pH monitoring, symptoms of GERD, and PPI use. Of 361 of 522 PERM patients underwent pH monitoring, abnormal acid exposure was detected in 47% of cases, reflux esophagitis, and LA grade C or D severity was detected in 4.6% at 3 months, and then 34.5% and 2.1% at 24 to 36 months, and then lower at 20.5% and then 0 at 6 years post-PERM. PPIs were taken by 52.1%, 47.2% and 56.4% of patients at 48, 60 and 72 months after PERM. There were no cases of Barrett's esophagus and esophageal cancer, and there was no relationship between these findings and the technique of PERM, either we go anterior or posterior. In conclusion, the rate of post-PERM reflux esophagitis decreased over time. However, approximately 50% of patients were requiring long-term PPI treatment. Our next study is looking at the efficacy and safety of G-PERM in lung transplant patients with refractory gastroparesis. This was a meta-analysis performed to evaluate the efficacy and safety of G-PERM in lung transplant patients with refractory gastroparesis. Studies published until 2022 reporting on the clinical efficacy in gastroparesis cardinal symptom index in the pre and post G-PERM period in lung transplant patients with refractory gastroparesis were included in this meta-analysis. The pooled effect estimates were calculated for clinical efficacy, defined as there being no residual symptoms requiring prokinetic agents or reinterventions. 4 studies were included in this meta-analysis comprising 104 patients. The pooled estimates for clinical efficacy of G-PERM was 83%. The pooled mean reduction in the gastroparesis cardinal symptom index score following procedure was -2. The 90-day mortality was 2.6%, with 1 patient dying from severe allograft rejection. In conclusion, G-PERM is an effective and safe strategy for lung transplant patients with refractory gastroparesis and should be considered as a therapeutic strategy in this population. Our next study looks at the management of gastric variceal bleeding, comparing endoscopic variceal ligation with balloon-occluded retrograde transvenous obliteration and TIPS. The aim of this study was to compare outcomes of variceal band ligation, TIPS, and BERTO in the management of bleeding gastric varices. The nationwide inpatient sample database was used to include cases involving gastric varices, bleeding based on intervention, including ligation, TIPS, and BERTO. 7,160 patients who were hospitalized with primary diagnosis of bleeding from gastric varices were included. Ligation was performed in 70%, TIPS in 8.7%, and BERTO in 4.9%. Median age of patients of 58 years, mean hospital stay was 5 days, with TIPS and BERTO cohort having the longest hospital stay. The median hospitalization charge was $72,476 US, which was highest for TIPS BERTO cohort. Mortality was highest in the TIPS cohort, followed by BERTO, then EGD with TIPS, then band ligation, and then EGD with BERTO. Hospitalized patients undergoing TIPS were associated with inpatient mortality that was higher than band ligation. In conclusion, patients undergoing TIPS and BERTO have increased inpatient mortality rate, longer hospital stay, complications, and higher hospitalization charges. Obesity surgery and risk of gastrointestinal malignancies in patients with
non-alcoholic fatty liver disease, and obesity. This is a multi-center matched cohort study. The aim of this study was to study the impact of bariatric surgery on the risk of GI malignancies in patients with NAFLD and obesity in a multi-center matched cohort study. This was a retrospective cohort study of patients with NAFLD who underwent obesity surgery and a matched cohort of non-bariatric surgery NAFLD patients. A 1-to-1 propensity score matching was performed and the risk of malignancy diagnosis at follow-up was calculated. After propensity score matching, 9,791 patients were included in each cohort for analysis. The mean follow-up for the bariatric surgery group was 4.8 years versus 5.1 years for the non-surgery group. The overall risk of a diagnosis of any malignancy was significantly lower in the bariatric surgery cohort at follow-up with hazard ratio of 0.72. The bariatric surgery cohort also observed a lower risk of NAFLD and obesity-related cancer. Among GI malignancies, there was a lower risk of colon, rectal, pancreatic, biliary, and hepatocellular malignancies in the bariatric surgery cohort. Bariatric surgery was found to be associated with a significantly lower risk of GI cancer diagnosis at follow-up in patients with NAFLD and obesity. Our next abstract is a 10-year outcomes of smoking cessation attempts in reducing low bone density disease and chronic pancreatitis. To determine if smoking cessation would lower the risk of low bone density in chronic pancreatitis patients, these authors performed a retrospective study using a health research network of electronic medical records. From 2002 to 2022, chronic pancreatitis patients with tobacco smoking history were divided into 2 cohorts: smoking cessation, which is cohort 1, and no smoking cessation, cohort 2. Propensity score matching was performed for demographic and medications, including pancreatic enzyme replacement, calcium and vitamin D supplementation. A 10-year outcome was assessed for osteoporosis, osteopenia, fractures, malnutrition, calcium deficiency, vitamin D deficiency, and mortality. These authors found that there was a significantly lower 10-year mortality with odds ratio of 0.85, p-value less than 0.001, and lower risk of malnutrition, odds ratio 0.77, p-value less than 0.001, in the smoking cessation cohort compared to the no smoking cessation cohort. There was no difference in the 10-year development of osteoporosis, osteopenia, or fractures between chronic pancreatitis patients with tobacco smoking history on chronic pancreatitis therapies, regardless of smoking cessation history. In conclusion, smoking cessation in chronic pancreatitis patients with smoking history is associated with a 10-year decreased risk of mortality and malnutrition. Our next abstract is looking at POEM with lower esophageal sphincter preservation for non-achalasia motility disorders. These authors aim to study the impact of esophageal sphincter preservation at POEM for non-achalasia esophageal motility disorders. These authors performed a prospective observational study of patients undergoing POEM for non-achalasia esophageal motility disorders. Eckhart scores were calculated pre-POEM and at 6 months, 1 year and 2 years post-POEM. Follow-up endoscopy was performed 6 months post-POEM. The primary outcome was clinical success, defined as an Eckhart score of 3 or less. The secondary outcome measure was esophagitis at 6 months post-endoscopy. These authors included 18 patients, 10 with jackhammers, and 8 patients with distal esophageal spasm. The median and pre-POEM Eckhart score was 6 and decreased to 1 at 6 months post-POEM and was sustained at 1 year post-POEM and at 2 years post-POEM. One patient of the 18 progressed achalasia type 3 and required POEM of the lower esophageal sphincter. 2 patients had esophagitis on follow endoscopy, and there were no serious adverse events in this patient cohort. In conclusion, endoscopic myotomy with LES preservation for non-achalasia esophageal motility disorder does not compromise clinical outcomes in long-term follow-up and is associated with less esophagitis. Our next abstract looks at endoscopic sleeve gastroplasty with anti-obesity medications, and this is an analysis of combination therapy, optimal timing, and agents. While efficacy of endoscopic sleeve gastroplasty and anti-obesity medications has been established, effective combination therapy and timing for combination are not known. In the single center retrospective study, patients were categorized into 3 groups: either monotherapy, i.e. having ESG only without any medications added. Number 2, combination therapy, the ESG with medications prescribed within 6 months prior to or after ESG, and 3, sequential therapy, in which medications were prescribed greater than 6 months prior to or after ESG. The outcome measure was to look at the percentage of total weight loss at 12 months. Success rate considered to be at least 10-month total body weight loss at 12 months, and the rate of serious adverse events. Of 224 patients, 34%, 31%, and 35% of patients underwent monotherapy, combination therapy, and sequential therapy, respectively. Among combination therapy patients, 30% were prescribed a regime that included GLP-1RA. In sequential therapy group, 81% were prescribed anti-obesity medications first, at least 6 months prior to ESG, while 90% underwent ESG first, at least more than 6 months followed by anti-obesity medication. At 12 months, patients with ESG and GLP-1RA medication combination therapy group experienced the greatest weight loss compared to monotherapy and sequential therapy. Patients started on medication first, followed by ESG at least 6 months later, experienced the least weight loss. While 100% in the ESG and GLP-1RA combination therapy experienced at least a 10% reduction in total weight loss, total body weight at 12 months, only 56% of medications followed by ESG sequential therapy reached this threshold. ESG-related serious adverse events were less than 2.6% and similar among the 3 groups. In conclusion, combination of ESG with GLP-1RA is superior to ESG alone. The optimal timing to add anti-obesity medication is within 6 months of ESG. Being on anti-obesity medication for more than 6 months prior to ESG was predictor of poor response following the procedure. Our next abstract looks at EUS-guided radiofrequency ablation versus surgical resection for the treatment of pancreatic insulinomas. The aim of this study was to compare EUS RFA and surgical resection for the treatment of pancreatic insulinoma. Patients with non-metastatic pancreatic insulinoma who underwent EUS RFA or surgical resection were compared using propensity score matching. Primary outcome was safety. Secondary outcomes were treatment effectiveness, length of stay, and recurrence. Treatment effectiveness was defined as complete resolution of symptoms. As you can see, 89 patients with the EUS RFA group, 89 patients in the pancreatectomy group. The median follow-up was significantly longer for the pancreatectomy group compared to the RFA group. Clinical efficacy was 95.5% in the RFA versus 100% in the pancreatectomy group. However, there was significantly lower risk of adverse events with a rate of 18% versus 61.8% in the pancreatectomy group. And recurrence was not calculated. Pancreatectomy was up to 17% in the RFA group. Therefore, EUS RFA appears to be safer than surgery and highly effective for the treatment of pancreatic insulinomas. When a lesion recurs after EUS RFA, it can be safely managed with a second EUS RFA or surgery. Our next study looks at pancreatic stone size and density to predict the number of ESWL sessions for successful fragmentation. The aim of the study was to evaluate the role of CT-based assessment of pancreatic duct stone characteristics in determining the technical efficacy of ESWL. This was a retrospective study of patients with pancreatic duct stones who underwent ESWL for stone fragmentation. Successful fragmentation was defined as the breakdown of stones to at least 3 millimeters. Demographic clinical CT data on pancreatic duct stones, SBK pain scores before and after fragmentation were recorded. Authors determined relationship between pancreatic duct stone size, density, and the number of required ESWL sessions for successful fragmentation. 187 subjects underwent ESWL. Significantly strong correlation was seen between the mean stone density and the number of ESWL sessions. A single metric was devised by dividing the product of stone size and density by 100, and this had a significant relationship with the number of ESWL sessions. The stone density metric also had area under the receiver operating curve of 0.929 in predicting the number of ESWL sessions, and density threshold of 895 Ansfield units could predict the need for multiple ESWL sessions with an accuracy of 89%. Pancreatic stone size and density measured by the mean attenuation coefficient on CT are strong predictors of the technical efficacy of ESWL in terms of determining the number of sessions required for successful fragmentation. The next abstract is looking at the evaluation of the impact of an AI-aided endoscopic diagnosis system for improving endoscopy quality and increasing the learning curve for beginning colonoscopy trainees. A prospective randomized multicenter study. The aim of this study was to compare the outcomes using the CAD-eye with conventional method, white light, in outpatients undergoing colonoscopies performed by GI trainees. This was a multicenter randomized trials where patients were divided into Group A and Group B. Group A was the CAD-eye group, and Group B was the white light imaging group. 6 trainees performed colonoscopies using back-to-back method in pairs. The primary endpoint was adenoma detection rate. Secondary endpoints were adenoma miss rate and 14 assessment of competency in endoscopy tool scores. 231 cases were enrolled with no significant difference in adenoma detection rate between the CAD-eye and white light groups, with 58.4 versus 61% respectively, with p-value of 0.690. There was a significantly lower adenoma detection rate and number of missed adenomas per patient in Group A versus Group B. Also, Group A also scored significantly higher on 2 items of competency in endoscopy tool scores: pathology identification and interpretation or identifying a location. The use of CAD-eye in trainees can decrease AMR and improve the ability to accurately locate and identify colorectal adenomas.
Thank you, Dr. Bang. That's tour de force there, just covering all those studies and many more. And again, thanks to all of you for inviting me to moderate this amazing session. So. And Shyam, please let me know if there's a group of questions that come up and I'll try to address them. But when I look and review the abstracts that Dr. Bang has gone over, I think of it in sort of 4 major categories. The first would be sort of endohepatology. The second is sort of necrosectomy. Third would be sort of pancreatic cyst characterization and surveillance. And the last would be sort of safety post sphincterotomy and ampulectomy. So that's kind of the major themes that I see here. For those that don't do EUS, doing EUS guided liver biopsy is really sort of catching on. And the question is it better than what we have already? Just because you can do it by EUS doesn't mean you should do it that way. And the other thing that's interesting, just some general information for the non-endosonographers, it's a little different doing an EUS guided biopsy of a metastatic lesion versus doing a liver biopsy. So there's different techniques. And if you look at what the proper technique is and sort of outcomes and complications, my gut sense is that I think we're underreporting some of the complications from EUS guided liver biopsies. And if you talk to Ken Chang, who really has put forth how to do portal pressure measurements. So their group was one of the pioneers and kind of worked with Cook Medical at that time. And the other group is the Geisinger group with Harshit Kar and Dr. David Deal. So it's not simple, like you just put a needle into the liver and come back and get a piece of tissue. There's some definite techniques. He does a biopsy, watches it to kind of create a plug, make sure that there's no bleeding. So what I'd like to leave you all with is that a EUS guided liver biopsy is not the same as doing a pancreatic mass biopsy, okay? And so if you just keep some of those things in mind, I thought the first group, the study that Dr. Bang reviewed by Dr. Dragavali from UAB, where this is a retrospective study. So they looked at what is the best methodology for doing these biopsies. Is it percutaneous? Is it a jugular biopsy, or is it an EUS guided biopsy? And in this retrospective study, the EUS guided approach fared the worst. Okay, doesn't mean that long term that we shouldn't be doing EUS guided biopsies, but I think we need to do some more studies to make sure what's the best method. The other thing that I attended the sessions. I thought a really good study was a prospective randomized study with a 19 gauge needle versus a 22 gauge for performing liver biopsies. That was also done by the David Deal group, and the 19 gauge needle outperformed. So I think one of the questions to the paper that was presented by UAB that Dr. Bang reviewed was, were all the biopsies done by a 19 gauge? She said yes, but it was retrospective. So I just wonder a little bit. So that's from endohepatology. The second major group of abstracts, I think, is sort of the necrosectomy. And I'll just pause for a second. Shyam, I don't know if you remember back when we had the EUS meeting in San Francisco, where before interventional EUS was coming about, and there was a paper that was published in GI Endoscopy. And one of the things that you mentioned in there is that we need to perform way better prospective randomized studies in endoscopic research, and certainly in EUS. And Shyam, you were still at UAB at the time when you did the prospective randomized study with pancreatic pseudocysts and whether surgical versus endoscopic is better. The reason I bring this up is that this year's DDW, I thought what was really neat was that there are lots of prospective randomized studies, still not enough, but way more than what we used to have 10 years ago. And I think that's a testament to, let's call it the Orlando Digestive Health Group. But certainly before you got to Orlando, you started insinuating or making a plea that prospective randomized studies are important. And you certainly have shown that. With that background, I thought it was really neat. I think your results that Dr. Bang presented with you as the primary author on this is when you do a direct endoscopic necrosectomy versus a step-up approach, if you go ahead and do the debridement at the first time, you're going to have better sort of outcomes with decreased length of stay and decreased number of reinventions. I think that's sort of my non-ERCP take-home message from that study. The third group I thought that was really important is we all know about pancreatic cysts and what a sort of conundrum that they pose for us. So the previous studies all looked at characterizing pancreatic cysts. Is this cyst potentially high-risk cyst or a sort of non-worrisome cyst? And I think now we've kind of understood which cysts are high risk. So the question is, which cysts should we follow up and which ones can you just leave alone and say, you know what, enough is enough? And so I thought this study, there are two studies. The first, again, these are in branch duct IPMNs, 4,000 patients. And what Dr. Bang pointed out is that you can discontinue surveillance in patients that are over 75 that have stability in their cyst for 5 years. So if the cyst is not growing after 5 years and the patient's 75, you probably don't need to do any more endoscopic ultrasounds or any other surveillance. And so I thought that was important. The other is last year that I mentioned the cyst fluid glucose was really performed quite well. And I think, again, the study looked at glucose in the cyst, CEA, and amphiregulin, which is a transmembrane glycoprotein. And the glucose from the cyst could differentiate mucinous from non-mucinous with an area under the curve that was really high at 0.88. CEA had less sensitivity but greater specificity, and amphiregulin did not perform well. So, the verdict's still out there. We use CEA cyst fluid. Some places are going to glucose. It's quite cheap, but it's hard to standardize that from the lab. So I think that's an important element. And there's some other studies, posters that I reviewed that are actually at the poster sessions where they can actually use the slides from the cysts. It goes back to Asif Khalid's group from Pittsburgh, where they did the PANDA studies, where it looks like there might be some characterization from the cysts. And sort of the last group of studies that I think in this session is looking at safety post-ampulectomy and post-sphincterotomy. And what I took away from this is the RCT of endocut versus pure cut. More post-ERCP pancreatitis was found with endocut, and if you had over 5 attempts at cannulation. So, and then the last one was the retrospective study of a snare ampulectomy. They did a logistic regression analysis. There's residual adenoma that was seen in about 50% of the patients. Piecemeal resection and extension to the bile duct predicted residual disease. And post-ampulectomy pancreatitis was seen in 15%, and that decreased with pancreatic duct stenting. And our group has shown this with published in endoscopic ultrasound that if you look by EUS, if you're doing an ampulectomy, the ones that you can do endoscopically are the ones that don't involve the bile duct. So that's where EUS is helpful. So any other, I mean, that's sort of my summary of the abstracts. Any other major questions, Shyam? Okay. Thank you again, Dr. Beng. Our next speaker is going to be Dr. Mitali Agarwal, and she's going to talk about general GI and inflammatory bowel disease.
Thank you so much, Dr. V, for inviting me to speak tonight, and Dr. Mishra for moderating the session. So we'll go ahead and get started with the first case, or the first abstract rather. So this was a study out of Harvard University and Tufts Medical Center evaluating the risk factors for development of post-colonoscopy colon cancer. The study defined post-colonoscopy colon cancer as cancer diagnosed after an index colonoscopy in which no cancer was found. The aim was to identify clinical features and risk factors towards developing post-colonoscopy colon cancer in 2 cohorts of patients. Cohort 1 were those who developed colon cancer within 6 to 48 months of colonoscopy, and cohort 2 were those who developed colon cancer after 48 months of colonoscopy. Over 198,000 colonoscopies were performed at Mass Gen and Brigham, out of which 121 colonoscopies occurred at less than 48 months and 86 occurred at more than 48 months. 90% of the colon cancers that occurred at less than 48 months occurred due to missed lesions. That means that either the cecum was not intubated or the prep was bad, or an inadequate exam in which a lesion was detected, but it was not removed or it was inadequately removed. The presence of a large polyp defined as greater than or equal to 1 centimeter was also associated with a higher risk of colon cancer at less than 48 months. So the authors concluded, and this is the take-home point for this study, 90% of cases of post-colonoscopy colon cancer at less than 48 months are avoidable with improved colonoscopy quality and lesion detection. Further, patients with large index polyps are at higher risk of developing post-colonoscopy colon cancer. So the aim of this next study was to evaluate the impact of artificial intelligence in polyp detection during colonoscopy in 4 community-based non-academic private practices between September 2020 and September 2021. Patients were randomized to undergo colonoscopy with or without artificial intelligence. The primary outcome measured adenomas per colonoscopy and adenomas per extraction. Secondary outcomes included serrated polyps per colonoscopy, non-adenomatous, non-serrated benign polyps per colonoscopy, adenoma and serrated polyp detection rate, and procedural time. 769 patients with similar demographics were randomized between the 2 arms. There was no significant difference in adenomas per colonoscopy in either arm. The number of benign polyps per colonoscopy were higher in the artificial intelligence group, resulting in a lower percentage of polyps that were removed that were actually adenomas. There was no difference in adenoma and serrated polyp detection rate in both groups. Withdrawal time was higher in the AI group compared to the non-AI group. However, when no polyps were identified, the withdrawal time was the same. So in conclusion, and the take-home point, is that artificial intelligence did not result in statistically significant difference in the number of adenomas detected. The other take-home point is that ChatGPT is not taking our jobs anytime soon. So the next study, the aim of this study is to evaluate empiric esophageal savory dilation in patients with non-obstructive dysphagia. This was a retrospective single-center study analyzing 132 patients with dysphagia who had empiric savory dilation without an obvious obstruction. Patients with a history of esophageal obstruction due to a stricture or motility disorder were excluded from the study. Primary outcome was to assess the improvement in dysphagia based on patient-reported outcomes during clinic or phone visit follow-up. Secondary outcomes was to evaluate admission within 12 months related to dysphagia, change in weight, and post-procedural adverse events. 54% of patients reported improvement in dysphagia after dilation. 56% of patients had weight gain within 9 to 15 months after initial dilation, and 76% of patients did not require any further dilation. No post-procedural related adverse events were reported. So the authors concluded, and the take-home point here is that empiric esophageal dilation using savory dilators is safe and can offer a benefit in patients with non-obstructive dysphagia. So we all know that a subset of patients with acute pancreatitis will develop recurrent pancreatitis, chronic pancreatitis, or pancreatic cancer. And the aim of this study was to identify risk factors associated with progression to other pancreatic diseases following an initial episode of acute pancreatitis. This was a prospective study of patients with acute pancreatitis across 17 Dutch hospitals from 2008 to 2015. Primary endpoints were development of recurrent pancreatitis, chronic pancreatitis, and pancreatic cancer. 1,184 patients were included in the study with a median follow-up of 9 years. 25% of patients developed recurrent pancreatitis, 6% developed chronic pancreatitis, and 1% developed pancreatic cancer. Patients with alcoholic pancreatitis had the highest risk of developing recurrent pancreatitis. Protective factors for recurrent pancreatitis included ERCP and cholecystectomy within 3 months of diagnosis of pancreatitis. Male sex, alcoholic and idiopathic pancreatitis, smoking, pancreatic intervention, and recurrent pancreatitis were independently associated with progression to chronic pancreatitis. This next study is out of Cleveland Clinic. The aim of this study was to assess whether bariatric surgery had a protective effect on de novo cancers in patients with obesity. This was a retrospective cohort study using a multi-institutional database called Trinetics. Patient with obesity defined as BMI over 35 and a history of bariatric surgery were identified in the database using ICD-10 codes. Patients with a history of prior malignancy, peptic ulcer disease, and ascites were excluded from the study. Assessment for de novo cancer started 1 year after the diagnosis of obesity or bariatric surgery. Patients were followed for 10 years from the initial diagnosis or from surgery. Over 1,500,000 patients were identified in the obesity group, and over 60,000 patients were identified in the bariatric surgery group. The incidence of obesity-associated de novo cancer at 10 years was over 50% lower in the bariatric surgery group compared to the non-surgical group. Further, bariatric surgery group had lower prevalence of breast, colon, liver, pancreatic, ovarian, and endometrial cancer compared to the non-surgical group. So the study concluded, and the take-home point here is that bariatric surgery can decrease the risk of de novo cancers in patients with obesity. This is another study out of Cleveland Clinic. The aim of this study was to evaluate the effect of celiac disease on pregnancy outcomes. This is another retrospective cohort study using multi-institutional database. In this case, it was the national inpatient sample of all pregnant women who delivered between 2015 and 2019. Over 12 million deliveries were identified in the database, out of which 10,555 births occurred in women with celiac disease. Women with celiac disease tended to be more likely white and older at the time of delivery compared to women without celiac disease. Further, pregnant women with celiac disease were at higher risk for pregnancy-associated complications such as preeclampsia, placenta previa, placental abruption, and delivery-related complications, including third or fourth degree lacerations or the need for forceps or vacuum-assisted delivery during vaginal delivery. Mothers with celiac disease were also less likely to have a full-term uncomplicated delivery. Length of stay was also higher in mothers with celiac disease. Babies born to mothers with celiac disease were more likely to be small for gestational age and experience distress during delivery. There was no difference in rate of stillbirth or need for cesarean section in mothers with celiac disease compared to those without celiac disease. This next study is on dupilumab, which is a monoclonal antibody that blocks IL-4 and IL-13 and is approved in the US and European Union for the treatment of eosinophilic esophagitis. In the past, it has demonstrated improvements in histologic, symptomatic, and endoscopic features after 24 weeks. This was a multi-center study to assess the outcomes at week 52 in patients with EoE on dupilumab with or without prior steroid exposure. Total of 111 patients received dupilumab for 52 weeks. Dupilumab was efficacious regardless of prior topical steroid use. Patients receiving dupilumab at week 52 further improved in achieving eosinophils less than or equal to 6 per high power field, and further had improvement in their dysphagia symptom questionnaire compared to week 24. At week 52, endoscopic and histologic scores improved as well. The study concluded that patients on weekly dupilumab demonstrated sustained improvements in histologic, symptomatic, and endoscopic aspects of EoE in adults and adolescents up to 52 weeks, despite prior steroid use. So now we will talk about the IBD section and IBD abstracts. So this first abstract is a meta-analysis of 9 studies with the aim to evaluate efficacy of high-definition white light endoscopy versus dye spray chromoendoscopy in detecting dysplasia in patients with IBD. The primary outcome was the proportion of patients identified with dysplasia, and secondary outcomes were proportion of patients identified with high-grade dysplasia and colonoscopy duration. In randomized controlled trials, dysplasia was detected in 19% of patients undergoing dye spray chromoendoscopy compared to 12% of patients undergoing high-definition white light. However, this was not statistically significant, but the trends did favor dye spray chromoendoscopy. Among non-randomized studies, dye spray chromoendoscopy was more effective than high-definition white light in detecting dysplasia, and this was statistically significant. There was no difference in the detection rate of high-grade dysplasia between the two groups in both randomized and non-randomized trials. The total procedure time was 6 minutes longer in the dye spray group compared to the high-definition white light group. In my opinion, this topic still remains controversial, with non-randomized data showing a robust benefit for dye spray chromoendoscopy compared to high-definition white light, with randomized data only showing a smaller potential benefit. So this next study is the Reprivo trial, which is a prospective placebo-controlled randomized trial out of Europe investigating the preventive effect of vedolizumab, which is an anti-integrin antibody on post-operative recurrence of Crohn's disease. Following ileocolonic resection, 80 patients were randomized to receive IV vedolizumab or placebo. 26 weeks after randomization, patients underwent ileocolonoscopy for assessment of recurrent Crohn's disease. Primary endpoint was endoscopic recurrence of Crohn's disease based on the Rutgert scoring system, and secondary endpoints were proportion of patients who had endoscopic recurrence greater than I2A, endoscopic remission defined as Rutgert's I0, and clinical recurrence. Patients on vedolizumab had better Rutgert scores, higher chance of low risk recurrence defined as Rutgert's less than I2A, higher chance of endoscopic remission compared to controls. So the study concluded, and the take-home point here is that vedolizumab is effective for prevention of post-operative recurrence of Crohn's disease. This study was recently published in the New England Journal of Medicine. It is a randomized, double-blind, placebo-controlled trial evaluating vedolizumab in patients with chronic antibiotic refractory pouchitis, specifically in ulcerative colitis patients who underwent ileoanal pouch anastomosis. Primary endpoints were changes in total ulceration and mucosal healing, as well as histologic healing. Total of 98 patients were randomized to vedolizumab versus placebo group. More patients treated with vedolizumab had greater reduction in ulcerated surface area, complete absence of ulceration and erosion, and remission. Vedolizumab was associated with better control markers of inflammation and improvement in endoscopic and histologic scores. And the authors concluded, the big take-home point here is that vedolizumab is a good option for patients with chronic antibiotic refractory pouchitis. This is actually one of my favorite studies because Kono-S anastomosis is done regularly at Cleveland Clinic. So Kono-S anastomosis is an anti-mesenteric functional end-to-end hand-sewn ileocolonic anastomosis performed in patients with Crohn's disease. Data in the past has suggested that Kono-S anastomosis reduces endoscopic and surgical recurrence of Crohn's disease. This study aimed to provide randomized control data comparing Kono-S anastomosis to conventional stapled ileocolonic side-to-side anastomosis in patients with Crohn's disease. The primary endpoints were endoscopic recurrence rate, defined as Rutgers score greater than I2, after 6 months of surgery, and surgical recurrence at 60 months. 119 patients were randomized into either arm, and at 6 months, 33% of patients had recurrence in the Kono-S group compared to 75% in the conventional group, and this was statistically significant. Severe postoperative recurrence, defined as Rutgers greater than or equal to I3, was found in 15% in the Kono-S group compared to 33% in the conventional group, and again, this was statistically significant. The results demonstrate a favorable trend for lower recurrence rate in patients who underwent Kono-S anastomosis compared to conventional side-to-side anastomosis in patients with Crohn's disease. And this is the last study from this section. This study involves CTP13. CTP13 is an infliximab biosimilar. Prior studies have shown that subcutaneous CTP13 has shown non-inferiority to intravenous CTP13 in IBD and rheumatoid arthritis patients. This study aimed to demonstrate the superiority of CTP13 sub-Q over placebo sub-Q for maintenance after induction with IV CTP13 in patients with Crohn's disease. So in the study, patients with moderate to severe Crohn's disease were treated with IV CTP13 for induction. Those who responded and had a clinical response were then randomized to either receive CTP13 sub-Q or placebo sub-Q for maintenance. Primary endpoints were week 54 clinical remission and endoscopic response. Safety was also evaluated at week 54. At week 54, clinical remission rate, endoscopic response was better in both the treatment arm compared to the placebo arm, both of which were statistically significant. All secondary endpoints, including improvement in abdominal pain, decrease in frequency of diarrhea, corticosteroid-free remission, were also better in the treatment arm compared to placebo. So the authors concluded that CTP13 sub-Q was more effective than placebo in clinical response and remission, endoscopic response and remission, and corticosteroid-free remission compared to placebo at week 54. Also, there were no safety concerns that were found in patients that were taking sub-Q CTP13.
Thank you, Dr. Agarwal. It's a lot of abstracts covering general GI as well as inflammatory bowel disease. Just full disclosure, I don't do inflammatory bowel disease, so we'll definitely lean on Dr. Navneethan to help us out here toward the end. As I was going through these abstracts, I think there's sort of 4 general themes that 4 to 5, if you want to kind of group them. First is really looking at quality of detection, and interval cancers, that's a huge deal, right? It's huge deal from our sort of moral, ethical, and then quality, and then litigation, right? Missed cancer is one of the greatest reasons of why gastroenterologists are sued. So anything that we can do to prevent missed cancers or interval cancers is going to be meaningful. So the first study, a cohort of 200,000 patients, they looked at if post-colonoscopy that cancer was detected in less than 4 years versus after 4 years, right? So if a cancer occurs after a clean colonoscopy in less than 4 years, then what happened, right? I mean, what went wrong? And so in this study, what they showed is that unfortunately, if you find a cancer less than 4 years after a colonoscopy, it's more likely to be at an advanced stage. So it probably was already there, and we or the colonoscopist missed this. The other thing is it's most likely to be at the site of a prior polypectomy. So I think this has been bantered or hammered into our practices is if you're going to do a polypectomy, make sure you get it all out. If you're not comfortable doing that polypectomy, send it to a place. It's okay to say we're not, I mean, I do this all the time. I'm not good at certain things, and have your partners who do good quality EMRs and ESDs and other things. So don't just feel like you can do it when you're not doing a complete job, because that's going to hurt the patients more. The other thing that from this study is that this was more commonly seen when the polyp was greater than 1 centimeter. So I think, these are important studies that we're going to continue to hopefully help us refine our practice. Just an FYI, we had Dr. Doug Rex, who, probably unarguably is one of the top colonoscopists in the world. We had him for 3 days. He was supposed to come to Wake Forest right at the start of COVID. I remember back 3 years ago, Doug had sent an email, said, Girish, my institution's not letting me travel. I said, what? They're a bunch of wimps. Why don't you just come, And then COVID happened, but he came back this past March. We did it as for colorectal cancer awareness. And a couple of things, he did internal medicine grand rounds and spent a lot of time with this. One of the things that I learned most, and I think I'd just like to share with you, is that the way Cologuard works is by looking at blood in these large polyps. That's the way Cologuard works. And that's what it's picking up. So big pedunculated polyps, Cologuard does great. But the sessile serrate adenomas, which we know in our practice, those are the most challenging polyps and the ones that we don't want to miss. There's not much blood supply in those. So a Cologuard test is not very good for SSAs. And that's something that I think really resonated with me, is that that's something we can talk to our patients. It's better for them to get screened versus not screened, but SSAs are a big deal. And if Cologuard's going to miss that, then that's important. The next major topic that Dr. Agarwal mentioned is sort of the artificial intelligence. Just by show of hands, how many folks here are using AI, GI Genius? All right. So about 2 or 3, so not that many, right? Yeah. So I think all of us should follow this literature very closely. I would point you to 2 major studies, both friends of the group. One is done by Rapici and all, published in Gut, that looked at what is the impact of AI in colonoscopy. And what they showed is that regardless of experience, right, we tend to think that having AI is useful for folks that are not as skilled, right? If you're a skilled colonoscopist, you don't need a machine to tell you whether you see a lesion or not. And they showed that regardless of the experience of endoscopy, that AI significantly helped detect lesions. And the other was, Mike Wallace published in Gastro. He was the first author. It was a large multi-center study. So there's a lot of good data that it does help. However, and Doug Rex pointed this out as well, is that if you look at private practice settings, does AI perform as well? And so I think that's going to be the next iteration, is can we generalize AI? And the study that Dr. Agarwal pointed out is they looked at, so there's a difference in CAD-E versus CAD-DX. DE is detection, DX is diagnosis. So can your artificial intelligence device, can it tell you what it is, or can it just detect? And I think there is going to be a time when, as you're doing a colonoscopy, when you remove the scope, then the report will actually print out the actual report of what was found. That's going to be quite powerful, but we're not quite there yet. But in this study, there's no difference between in 4 private practice groups that use this in the adenoma per colonoscopy in the CAD-E versus the non-CAD-E group. The ADR detection rate was the same, even with SSAs. The only difference was that the mean withdrawal time was about 1 minute greater in the CAD-E group. So I think what I would say is, there's promise, but we need to do some better studies, and perhaps the generalizability right now in all the studies that are being published is not quite there. The second group, second major topic was what happens after an attack of acute pancreatitis. So this was a large, almost a 1,200 patient study with a 9-year follow-up. We all know that these patients with recurrent pancreatitis, they're troublesome because we can't figure out what the cause of the pancreatitis is. So in this study, followed over 9 years, 25% developed another attack of pancreatitis and 6 developed chronic pancreatitis. And we all know who those patients are going to be that develop chronic pancreatitis. These are the patients that are going to be alcohol users, male, smoking, and have had prior pancreatic interventions. So these are the ones that you really that can get recurrent pancreatitis. There's 1% risk of developing pancreatic cancer in this group with a 9-year follow-up. So that's significant out of 1,200 patients. So I think the other take-home message from this study, and we've seen this before, is when in our EUS practices, is you get the patient referred to you for recurrent pancreatitis, and you look and you look and you look and you don't see a mass there, and 5 years later they have pancreatic cancer, and you've done everything you can. You've sent them for an MRI, you've repeated their EUS, but that's the group, and especially if they're over 60, just keep that high index of suspicion. The next study that I thought was really neat was the dupilumab for EOE. Almost 70% had response, whether they had prior response to topical steroids or not. So I think that's key. And Uday, I'll get your advice, but I thought the last group of studies that I thought were impactful were the questions: what can we do to decrease post-op recurrence of Crohn's disease after ileocolonic resection? So Dr. Agarwal reviewed this study. There were 80 patients that were randomized at 4 weeks. So at 4 weeks, patients got randomized to IV vedolizumab versus placebo, and then they were scoped about 7 months afterwards. And what they looked at was the Rutgers score, which is the endoscopic healing, and 80% had improvement in the Rutgers score in folks that got the IV vedolizumab. I don't think this paper has been published yet, so we'll wait. And then the last study, I think for pouchitis, I know at your IBD conference, one of my colleagues, Dr. Jeannie Ashburn, was here. She's a colorectal surgeon trained at Cleveland Clinic, so we do a lot of stuff together. She has one of the largest pouch experiences, or redo pouches in the world, in the country. So for pouchitis, really the only prospective randomized study that has been helpful has been VSL3. Nothing else, to my knowledge, and we'll see what Uday thinks, but this is the first study, and if it's published in New England Journal, it's got to be a pretty well done study where vedolizumab seems to be effective for pouchitis compared to placebo randomized control trial. So this is the first one that I'm aware of outside of VSL3. Uday, any comments on those IBD studies if you want to come up? And after Uday, then Dr. Murali will do our hepatology reviews.
Thank you, Girish, and it's a pleasure to have you here in Orlando. We just saw him last week at DDW, so it's a pleasure to see you back again. And I think Dr. Agarwal did a great presentation on the studies on IBD, so I don't want to reinforce it, but I just want to tell some practical cues about these studies and what it means really. The first study on chromo versus high definition white light is the controversial topic day in and day out. We had a debate in DDW last week when I presented that dye spray chromatoscopy should be the way to go. In my opinion, I think both are very useful, high definition and dye-based chromatoscopy, or even virtual. The NBI or the blue light imaging with Fuji scope are all good. But to detect dysplasia in IBD, you need a lot more training. So in my opinion, if you don't use dye-based chromatoscopy, you're going to miss lesions if you're not experiencing IBD dysplasia. While if you're very experienced, if you see a lot of IBD dysplasia, and then if you do a good high definition white light, it's sufficient, in my opinion. So if you're in practice not doing enough dysplasia detection in general, I think you should use dye-based chromoendoscopy or virtual chromoendoscopy in the practice. That's my opinion. But if you use a lot of the studies from RCTs which are published or from tertiary referral centers saying that both are equivalent. But if you look at real practice, dye-based actually is much better than high definition white light endoscopy. So practically, I would say for all folks who don't see that much dysplasia, you should still do virtual or dye-based chromo, while tertiary experience centers, they can do dye-based or high definition white light. Both are equivalent in my opinion. But I universally use dye-based or virtual chromoendoscopy just because, in my opinion, detection is, in my opinion, is still better. And the virtual chromoendoscopy makes it much easier compared to the dye-based chromoendoscopy. You can just click a button. You can use NBI, or with the Fugiscope, they have the BLI imaging or the LCI imaging, which is very advantageous to look at the dysplasia because it highlights the colors very clearly. So I think those are options. The second study, I think a couple of studies are based on drugs. I think vedolizumab, one for pouchitis and one for post-op recurrence. A take-home message I would say is Vedo is a very, very safe drug. In my opinion, it's one of the safest drugs we have for IBD treatment. The advantage we have with Vedo is in the study, they said that they started treatment within 4 weeks after surgery. That's very important. In my practice, or on our practices in IBD center in our place, within 2 weeks after surgery, they can start the drug. So that's an important take-home message. So start them early because once you cut the resection, the stricture is gone. You want to treat early before the disease recurs. So if you wait 3 to 6 months and start treatment after that, high likelihood recurrence is going to come back. So start within 2 weeks after surgical resection. The drugs are very safe, very effective, and that the studies suppose that. So, the patient failed vedolizumab before surgery, you can still do after surgery. It doesn't mean that they're not going to respond because once you cut this resection area, it basically starts fresh. You have a fresh set of eyes to start the treatment, and at that point, vedolizumab may still work. The chronic pouchitis data, I agree with Dr. Mishra. I think there's not much data for pouchitis because it's not very sexy. It's not very, it's a very difficult disease to manage. So there's not, industry doesn't want to spend money in that area because it's not an indication. Even the Vedo, I met the chief medical officer from Takeda, which did the trial. They're not interested to do the study because it's not a high yield, high population patients you see in practice, but they finally spent the money for it. And it's going to be, even with this study, they're not going to get an indication from the FDA. FDA is not going to approve for pouchitis as an indication. So it's going to be a challenging aspect for them. But in our practice, in patients who fail antibiotics and refractory pouchitis, vedolizumab should be the first choice. There's a small subset of patients who have Crohn's disease, like phenotype of the pouch, where they have a severe disease. In those patients, I would not use vedolizumab as a first line. I think in those patients, either is anti-TNF, anti-interleukins. But the small subset of patients who are typical pouchitis, pouch inflammation, normal afferent limb of the pouch, I think Vedo is the first line choice in my practice. And I think the CONO-S study was very interesting because it is very, very practical. For people who do a lot of Crohn's post-op colonoscopies, you'll see that if we do an end-to-side anastomosis, it's very hard to intubate the neo-TI because up almost like a retroflux in the right colon and get into the neo-TI. But if you do an end-to-end anastomosis, it's very easy to intubate the TI, easier to manage. And if you have a narrowing, you can dilate it easier compared to an acute angle where you cannot do a dilation or you cannot do a stricturotomy, things like that. So I used to CONO because I attend the Cleveland Clinic as well. We do CONO as anastomosis all the time. Easy to manage recurrences, but we don't see that in Florida. It's almost like I see like 1 in 100 patients after surgery, we see CONO as anastomosis. But this study showed that CONO is superior. So hopefully the surgeons here practice more, but it requires a little bit more training in that technique. So I don't know, it will change in the practice, but that's a good advantage to have if you have that thing. And the last study was on subcutaneous infliximab, which is just coming, I think, just because it makes their life easier. After the IV induction is done, the patients can transition to IV sub-Q at home. So don't need to go to the hospital and get the infusion. So it's very advantageous. But that's a few practical tidbits I would take from all these trials we have at this point.
Good evening, everyone. I'm very happy to be here. I know everyone is getting ready for food and wine. So I want to apologize. Most of the studies are going to be on alcohol-associated fatty liver and metabolic syndrome-associated fatty liver disease. So I'm sorry about that. So the first study is on the impact of moderate to severe protein-calorie malnutrition on outcomes and healthcare resources utilization in patients with acute alcoholic hepatitis. So malnutrition is commonly seen in hospitalized patients with acute alcoholic hepatitis. So the authors aimed to evaluate the effect of moderate to severe protein calorie malnutrition on outcomes and healthcare utilization in hospitalized patients with acute alcoholic hepatitis. So they used the national inpatient sample from 2016 to 2020. They retrospectively analyzed the database using ICD-10 codes. They identified discharges with a diagnosis of alcoholic hepatitis and concomitant moderate to severe malnutrition. The primary outcome was inpatient mortality. The secondary outcomes included rates of endotracheal intubation, acute kidney injury, shock, encephalopathy, and sepsis. Total hospital charges, cost, length of stay were calculated. Multivariate logistic regression analysis was performed to adjust for potential confounders. A total of 664,000 inpatients with acute alcoholic hepatitis were studied, of which 9.3% had moderate to severe protein calorie malnutrition. On adjusted analysis, malnourished patients had significantly higher odds of dying during admission, adjusted odds ratio of 2.46. Patients with malnutrition had significantly longer length of stay and significantly higher healthcare charges and hospital costs. They were also more likely to suffer from acute respiratory failure, sepsis, spontaneous bacterial peritonitis, hemodialysis, paralytic ileus, and they needed more transfusion of blood products. So in conclusion, the authors made the conclusion that patients diagnosed with moderate to severe protein calorie malnutrition during hospital admission for acute alcoholic hepatitis, they have higher mortality, longer hospital length of stay, and higher healthcare burden. The study highlights the importance of screening patients with acute alcoholic hepatitis for malnutrition, to institute early nutritional support, and begin patient education of its poor outcome. A second study is on the use and utility of liver biopsy in a dedicated fatty liver disease clinic incorporating metabolic health care. So non-alcoholic fatty liver disease is often a presumptive diagnosis that is made after excluding alternative liver diseases and hazardous alcohol use in patients with metabolic risk factors. With the advent of non-invasive fibrosis testing like elastography, the role of liver biopsy is less clear. In order to understand the role of liver biopsy in patients with non-alcoholic fatty liver disease, the authors studied the clinical and histologic data of patients at the Yale Fatty Liver Disease Program. They retrospectively analyzed data for 965 adult patients who received care in their fatty liver disease clinic from 2018 to 2022. They identified patients who received a liver biopsy to compare the demographic, clinical, fibrosis score, and weight loss interventions compared to those who did not receive the liver biopsy. They did perform a multivariate regression analysis to assess clinical outcomes. So they included 965 patients with fatty liver disease, of whom 20% received a liver biopsy. So 20% of patients with fatty liver disease seen in their clinic received liver biopsy. They included about 131 for the analysis. 65% of these biopsies was performed to stage their fibrosis, 13% to establish the diagnosis, and 22% for both. They noted that patients who received the liver biopsies were older, they had diabetes, and they were more likely to have advanced fibrosis on initial transient elastography, as well as the FIB-4 score. Interestingly, in 33% of patients who received liver biopsy, a new diagnosis of cirrhosis was made. So these were patients who did not have evidence of cirrhosis on non-invasive testing. And more interestingly, on liver histology, 40% of patients who had biopsy had an alternative liver disease. Among these, about 26.7% had steatohepatitis that was more suggestive of alcohol-associated liver disease. Among patients who had steatohepatitis, the NAFLD activity score was greater than 3 in about 48% of patients. And these are the patients who are potential clinical trial candidates. So the authors concluded that in a specialty clinic to which patients are referred for fatty liver disease, liver biopsy remained necessary in a substantial proportion of patients for fibrosis staging and diagnostic testing, despite the routine availability of non-invasive tests. I think the conclusion, which is very relevant in our clinical practice, is that liver biopsy remains an important diagnostic and fibrosis staging test, and the results from the liver biopsy will impact patient outcomes. The next study is on hepatic decompensation and hepatocellular carcinoma risk in patients with non-alcoholic fatty liver disease, with and without diabetes. This is a systematic review and individual patient data meta-analysis. So previous studies have shown that type 2 diabetes mellitus is associated with fibrosis progression in patients with NAFLD. The authors here conducted an individual patient data meta-analysis to examine the risk of hepatic decompensation and hepatocellular cancer in fatty liver disease patients with and without diabetes. They included 6 well-characterized adult cohorts from 3 different countries, United States, Japan, and Turkey. All patients underwent magnetic resonance elastography, and they were followed longitudinally for hepatic decompensation, hepatocellular cancer, and death. The primary outcome was hepatic decompensation, which is defined as the development of ascites, hepatic encephalopathy, or esophageal varices requiring treatment. And they compared patients with and without diabetes. The secondary outcome was development of hepatocellular cancer. They included 1732 patients who had longitudinal data, and none of these patients had any decompensation at baseline. The mean age was 57.8. The mean BMI was 31.32. Over a median follow-up of 3 years, 112 patients developed hepatic decompensation. And patients with type 2 diabetes had a significantly higher incidence of hepatic decompensation at 1 year, 3.3% versus 1%, at 3 years, 7% versus 2.3%, and at 5 years, almost 10% versus 2.7%, compared to those who did not have diabetes. And these findings remained consistent in subgroup analysis when adjusted for their baseline liver stiffness as determined by magnetic resonance elastography. So when they did a multivariate Cox proportional hazards model that was adjusted for age, sex, BMI, and ethnicity, again, type 2 diabetes mellitus was associated with a higher risk of decompensation with an adjusted hazard ratio of 2.1. Similarly, patients with type 2 diabetes had a significantly higher cumulative incidence of liver cancer at 1 year, 3 years, and 5 years. And finally, when they did a multivariable Cox proportional hazards model that is adjusted for age, sex, BMI, and ethnicity, again, the presence of diabetes was associated with a higher risk of liver cancer. Hazard ratio is almost 5.1. So to conclude, in a well-characterized large cohort of patients with fatty liver disease, the authors demonstrated that patients with type 2 diabetes have a significantly higher risk of hepatic decompensation and hepatocellular carcinoma. And clearly, these data have important implications for clinical practice and for clinical trial design. Next study is on the impact of non-alcoholic fatty liver disease in pregnancy. So as we all know, non-alcoholic fatty liver disease has become the leading cause of liver disease and cirrhosis in the United States. And the same implications is seen in patients at the reproductive age. So the studies on fatty liver disease in pregnant women are limited. So the authors aim to study the effect of non-alcoholic fatty liver disease on pregnancy outcomes using a large database. So they performed a case control study with a national inpatient sample using ICD-10 codes to identify patients with pregnancy and who had a prior history of fatty liver disease. The primary outcome were differences in mortality rate and rates of inpatient outcomes and complications between those who had fatty liver disease and those who did not. So they included over 12 million patients. 0.06% had fatty liver disease. Patients with fatty liver disease were older. They were more likely to be Hispanic or white. Patients with fatty liver disease had higher prevalence of major antepartum complications like preeclampsia, 21% versus 5.4%, and gestational diabetes, 24% versus 7.4%. NAFLD cohort are more likely to undergo induction of labor or cesarean delivery. And These two are the most important. NAFLD group had higher severe maternal morbidity conditions, shock, ARDS, DIC, acute renal failure, and postpartum hemorrhage, all of which was statistically significant. Sadly, patients with fatty liver disease also had higher fetal complications. Preterm birth was 12% versus 5.7%. Intrauterine growth restriction was also higher. Fetal distress and stillbirth was also higher in patients with fatty liver disease. So the study concludes that fatty liver disease is significantly associated with adverse events, severe maternal morbidity, and major fetal complications. With fatty liver disease prevalence on the rise, it should be considered a high-risk condition in pregnancy, and maternal fetal medicine care is recommended. So one thing about the study that I would be interested to see when they publish it is the baseline fibrosis in patients with fatty liver disease, and whether the same applies to patients with lower fibrosis scores. We're moving on to lean NAFLD. So this is a nationwide analysis of lean NAFLD prevalence and mortality from 2017 to 2019. So NAFLD encompasses a disease spectrum believed to be associated with obese individuals. But we know that patients whose BMI is less than 24.5 can also develop fatty liver disease. Recently conducted studies have shown that patients with lean NAFLD may have an increased odds of mortality. So the authors performed a nationwide analysis to identify the prevalence of lean NAFLD as well as the mortality outcomes in the time frame between 2017 and 2019. So they used the National Inpatient Sample Database. They identified all adult patients with NAFLD using the ICD-10 codes. So they characterized BMI into category 1, which is a BMI 19.9 or less, category 2, 20 to 24.9, category 3 is 25 to 29.9, category 4 is 30 to 34.9, category 5 is 35 to 39.9, and category 6 is with a BMI that's more than 40. They initially did a univariate screen, and this was followed by a multivariate logistic regression to adjust for potential hospital and patient level confounders. An increasing total of 417,000, 476,000, and 532,000 admissions with fatty liver disease was noted in 2017, 2018, and 2019, respectively. The prevalence of lean NAFLD has been increasing over the years, 2.65% in 2017, 2.71% in 2018, and 2.9% in 2019. So when they did multivariate analysis, category 1 NAFLD, which is BMI less than or equal to 19.9, they had increased odds of mortality compared to all other BMI subgroups in all 3 years. 2017, the odds ratio was 1.79, statistically significant. 2018, 1.81, and in 2019, 1.71. All were statistically significant. So within the lean NAFLD BMI category, the odds of mortality are higher in NAFLD category 1 as compared to all other BMI subclasses. Clearly, more research is needed in this field to understand why patients with lean NAFLD may have a high mortality as compared to those who have a BMI more than 25. So moving on to our liver transplant. So changing trends in the etiology of acute or chronic liver failure as an indication for liver transplant. The authors aim to assess the trends in liver transplantation for acute and chronic liver failure in older patients, which they defined as greater than or equal to 65, in comparison to younger patients, 18 to 65 years old. In addition, they wanted to explore the differences in the etiology of underlying cirrhosis between the two age cohorts. All adults who underwent liver transplant for acute or chronic liver failure between 2005 to 2021 were identified using the UNOS database, and they were divided into older and younger age groups. The definition of ACLF was based on the Easel-Cliff criteria. They grouped the etiology of cirrhosis into alcohol-related liver disease, metabolic syndrome-associated fatty liver disease, hepatitis C, cryptogenic cirrhosis, and PBC or PSC. The transplant years were divided into 3 eras. The first is the pre-direct acting antiviral era, the DAA era, and the COVID pandemic era. So looking at the older adults, between 2005 and 2021, a total of 2,142 patients underwent liver transplant, Of these, 26% had NASH, 25% had alcohol-associated liver disease, 10% had hepatitis C, and 8% had PBC or PSC. In the year 2005, only 66 older patients underwent transplant, but this increased by 262% to 239 patients in 2021. Also in 2021, NASH overtook alcohol-associated liver disease as the most common cause for liver transplant in older patients. When you look at younger adults, about 16,931 younger patients with ACLF underwent liver transplant, and this increased from 648 in 2005 to 1908 in 2001. And the most prevalent etiology for underlying cirrhosis in younger patients was alcohol-associated liver disease at 44%, followed by hepatitis C at 15% and NASH at 10%. In the years 2020 and 2021, alcohol-associated liver disease leading to ACLF was responsible for 62% and 68% of all liver transplants in young patients. So if you look at these graphs, figure 1 shows the trends in liver transplant for ACLF by etiology in older patients. And if you can see, fatty liver disease has been gradually increasing, and except for 2020, that is the COVID year, except for 2020, in all other years, NASH is the most common indication for liver transplant. Whereas if you look at younger adults, clearly there is alcohol-associated liver disease is the most common cause for liver transplant in younger adults. So to conclude, there is a considerable variation in the etiology of underlying cirrhosis in ACLF between older and younger patients, and liver transplant for ACLF has consistently increased across all age groups, but more profound in the older population. Overall, NASH is the leading cause of ACLF in the older population, while in the younger patients who undergo liver transplant, alcohol-associated liver disease remains the most prevalent etiology, and unfortunately, it continues to increase at an alarmingly high rate. So the last study is on the safety and efficacy analysis from the REGENERATE trial of obeticholic acid for the treatment of NASH. So NASH is last study in NASH, we'll move on. NASH is a major cause of liver-related morbidity and mortality. So fibrosis is the best predictor of clinical outcomes in NASH. Obeticholic acid is a first-in-class farnesoid X receptor agonist that demonstrated efficacy as an anti-fibrotic agent in the phase 3 REGENERATE trial in NASH. The goal of this study was to confirm the original 18-month biopsy efficacy result and to provide additional safety data from more than 8,000 total subject years, with nearly 1,000 subjects receiving obeticholic acid for greater than or equal to 4 years in the REGENERATE study. It was a multi-center, randomized, double-blind, placebo-controlled phase 3 study. Subjects were randomized to receive once-daily oral placebo, or 10 milligrams of obeticholic acid, or 25 milligrams of obeticholic acid. And safety data were evaluated from 2,477 subjects who received at least one dose of the study drug. A consensus method using a panel of 3 pathologists for histologic assessment of liver biopsies, as per the NASH CRN criteria, was employed to confirm the results of the original 18-month interim efficacy analysis. So the treatment emergent adverse events, serious treatment emergent adverse events and deaths were balanced across the treatment groups. Pruritus was the most common adverse event in all 3 treatment groups. Its incidence was higher in both the obeticholic acid groups as compared to placebo. For adverse events of special interest, the incidence of pancreatitis and hepatic disorders was similar between the obeticholic acid group and placebo group. The incidence of gallbladder and gallstone related adverse events was higher in both the obeticholic acid groups as compared to placebo, though most of these were mild to moderate in severity and were managed with temporary drug interruption and usual clinical care. And in the new analysis of the intent to treat population using a consensus read method, 22.4% of subjects receiving obeticholic acid experienced at least one stage improvement of fibrosis with no worsening of NASH at month 18, versus only 9.6% of subjects receiving placebo. So to conclude, in the ongoing REGENERATE trial, subjects receiving obeticholic acid were twice as likely to experience improvement in liver fibrosis with no worsening of NASH compared to subjects receiving placebo at 18 months using two different histologic methodologies. The confirmed anti-fibrotic effect in liver histology, together with extended exposure within the largest safety database in NASH, demonstrated that obeticholic acid was generally safe and well tolerated, supporting the long-term use of obeticholic acid to treat pre-cirrhotic NASH fibrosis. These are encouraging results considering we do not have any good treatment options for NASH at this time. Okay. So the last study for the presentation today is on diagnostic paracentesis within 1 day of admission is associated with reduced mortality and shorter length of stay in hospitalized patients with cirrhosis and ascites. We all know that diagnostic paracentesis is recommended by society guidelines for all hospitalized patients with cirrhosis and ascites, regardless of the reason for admission. About 25% of patients with ascites develop SBP. And recent literature has reported that delayed paracentesis is associated with a 2.7 times increased risk of mortality, with a 3.3% increase in mortality for every hour delayed. Currently, no specific time frame recommendations exist for inpatient paracentesis. So the authors conducted a systematic review and meta-analysis to evaluate outcomes among patients receiving paracentesis within 12 hours, 24, and greater than 24 hours. So they used multiple medical databases to identify the studies for the meta-analysis. The outcomes of interest included mortality, hospital length of stay between early versus delayed paracentesis. They included 8 retrospective studies. 116,000 patients were included in the final meta-analysis. The pooled risk of inpatient mortality was significantly lower in patients who underwent early as compared to delayed paracentesis. And they did a subgroup analysis. There was a trend towards reduced mortality in patients who underwent paracentesis within 12 hours compared to within 24 hours, though this was not statistically significant. The risk of inpatient mortality was significantly lower in patients who underwent diagnostic paracentesis compared to no paracentesis. Also, the length of hospital stay was significantly shorter by 5.38 days in patients who underwent early paracentesis as compared to those who underwent delayed paracentesis. So to conclude, early diagnostic paracentesis is associated with a significantly reduced mortality and shorter length of stay in hospitalized patients with cirrhosis and ascites. And paracentesis should be performed within 1 day of admission, with efforts to perform the procedure within 12 hours whenever possible. And I think this is an extremely important study because we do see patients not having received a paracentesis for 1 to 2 days after their admission. And we always try to see if they can get a diagnostic paracentesis in the emergency room itself so that we can make treatment decisions. And also to get a paracentesis before the patient receives IV antibiotics in the emergency room. Thank you.
All right. Thank you, Dr. Murali, for bringing it home there with the hepatology stuff. So as we try to wrap up here, thinking about this segment, I kind of think of it in several big groups. The first is, what can we do to improve outcomes in alcoholic hepatitis? The second is just a bunch of different, the whole entity of NAFLD is significant. Sort of the third was, how, liver transplant recipients. And finally, is there anything we can do to improve outcomes in patients with NASH? So the first study that Dr. Murali pointed out, to date, really, what do we have with alcoholic hepatitis? It's prednisone. That and maybe pentoxifylline. There's some studies looking at N-acetylcysteine. There's one study from the Lilly group in France where they did liver transplants in acute alcoholic hepatitis with some good outcomes, but we really don't have much. So if we don't have much in terms of what can we do to treat patients with alcoholic hepatitis, what can we do outside of medical treatment? And so Dr. Murali pointed out in the study that protein calorie malnutrition is extremely important. Patients that had lower protein calorie had a much higher mortality, greater length of stay, and higher healthcare burden. So the next set of studies I think that are important to include are those with NAFLD. We look at non-invasive methods for NAFLD, FiberSure, FibroScan, MR, elastography. And in this center at Yale, which is one of the largest liver centers, they come back to saying that you really do need liver biopsies, which is the gold standard. And I think there's no doubt that a liver biopsy has a place. Finally, the finding of patients that have NAFLD, that have type 2 diabetes, are going to have much worse outcomes. So the study showed that a much higher risk of hepatocellular cancer and hepatic decompensation. Similarly, patients with NAFLD had more antepartum complications, more likely to undergo induction labor, more fetal complications, and also patients that have NAFLD and are pregnant are going to have more maternal complications with more risk of ARDS, shock, and DIC. The whole notion of lean NAFLD, that was foreign to me. I'd never heard of the term, so I had to look it up. I'm sure for the hepatologist, that's a well-known entity, but for me, I never knew what lean NAFLD was. But there's got to be some physiologic reason that despite not being obese, patients that have NAFLD are going to do worse, and that's what this study pointed out. The last study that Dr. Murali pointed out was NASH and obeticholic acid. In the treated arm, they showed a one-stage improvement in their fibrosis score compared to placebo. Their side effects are pretty minimal, and if they stopped treatment, the side effects went away. So I think this seems to be a fairly safe drug in pre-cirrhotic NASH fibrosis. And then the last group is, in terms of changing trends in liver transplant recipients, what you told us is that in patients that are less than 65, it's alcoholic liver disease. In those that are greater than 65, NASH is the most common cause for liver transplantation. So with that, I'll wrap up. I think we're not too far off on time. Again, I just want to thank the entire digestive health group at Orlando Health for inviting me back, and have a great dinner, everyone.
So this is my final wrap up. I want to thank our online audience. I have an iPad and I could see people from China, Japan, India, Australia, Norway, Japan joining us for this meeting. Thanks so much. And Thailand again. Thanks so much for joining, particularly also those from the United States. And I think it's a different time zones that you took the time to spend watching us and learning from this experience is great. Second, I think we are only as good as we are surrounded by the colleagues that work with us. I think Murali, Dr. Bang, and Dr. Agarwal did a fantastic job. So we at our Digestive Health Institute work with very, very good people, and going to work with them is an absolute education. And this is the only time in the year I learned something about liver and IBD. So thanks for educating me. And finally, our friends and professional colleagues from Central Florida. Today is a Saturday. Everybody decided to come and spend this evening with us, driving so long. So thanks for joining us this evening, and thanks so much, guys. And hopefully we'll meet again next year. And until then, goodbye, and hopefully you guys will have a good weekend. Thank you.